Well, I'd like to invite Dr. Rahimi, another vascular surgeon who joined our institution about a year ago, and he's going to discuss with us peripheral arterial disease and management.
Good afternoon. My name is Maham Rahimi. I'm going to talk to you about peripheral arterial disease. Let me see if I can make this work. There we go. I have no disclosure. Let's define peripheral arterial disease. The picture on the right is a picture from JAMA 2004 showing a patient, typical patient with peripheral arterial disease. And what it is basically decreasing the blood flow to the lower extremity because of the diseased artery plaque formation, for instance. And they get pain in their calf or their thigh, and that's called claudication. Approximately 12 million Americans are affected with peripheral arterial disease, and the risk factors are increased with age, smoking, diabetes, hyperlipidemia, obesity, and renal insufficiency. Sorry if it's not coming too perfectly, but this is the most important part of my talk. What is the natural history of peripheral arterial disease? And when they looked at after 5 years outcome, it divided to two categories. One, does this intermittent claudication, pain in the calf, in the thigh, progresses? And what they found out is that actually 70 to 80% of the patient, they are stable claudication, they do not get worsened. Only 20-30% do, and 1 to 3% they get rest pain or ulcers with this claudication. But the most important part is what happened to this patient after 5 years. The morbidity and mortality because of the cardiovascular disease as a whole picture is looked at. And they saw that 20% will die from MI or stroke, and mortality is up to 10 to 15%. So the question arises, if a patient comes to intermittent claudication, what should we do? So let's go ahead through diagnosis first, and then we'll go through the treatment. The first recommendation is if somebody comes in with the symptoms of peripheral vascular disease, with a claudication, pain on lower extremity, signs suggesting peripheral arterial disease, ulcer, or rest pain, they should do something called ankle brachial index. They basically put a blood pressure cuff on their upper extremity, use the highest number to compare it to the lower extremity. And the number approximately close to 1 is normal. Anything below that is considered abnormal. However, if it's higher than 1.3, it just indicates the artery is so diseased that this study is not appropriate for, and other modalities should be used. Again, the question is when to do the ankle brachial index if the patient has symptoms, or if they don't have any symptoms but they have abnormal exam, the physician or nurse practitioner or the nurse unable to palpate the distal pulse, and the patient is more than 70 years old, the smokers, diabetes, they have the risk factors. Now, if they're unable to do ankle brachial index and they're symptomatic, they can do physiologic non-invasive studies that they can look at this more complete look at it, ankle brachial index. They put blood pressure cuff not only at ankle, but at the different levels on the thigh and lower extremity, and look at these waveforms. And if the amplitude changes, the waveform changes, that indicates there is peripheral arterial disease. So that's how it gets diagnosed. If the patient is symptomatic and deemed to have revascularization, at that time the recommendation is to do some kind of imaging studies, either ultrasound, CT, MRI, or even angiogram. The patient that are asymptomatic with a peripheral arterial disease, a multidisciplinary team needs to look at the patient, and they need to suggest to the patient to stop smoking, educate them about the signs and symptoms of progression, diabetic and sugar management, and the recommendation from our society is against invasive treatment if the patient is asymptomatic, regardless of their hemodynamic measures on the ABI. If the patient, however, is symptomatic, in addition to what I mentioned previously, they need to look at their cardiovascular risk factor and try to decrease that. As I said, the morbidity and mortality is high for this patient with intermediate claudication. And if they have symptoms, we should make sure that the patient is on cholesterol controlling medication, antiplatelet, aspirin. If they don't have congestive heart failure evident from echo, they should trial 3 months of cilostazol, or if they have congestive congestive heart failure, they should try pentoxifylline and some kind of exercise program. And what that recommendation is to walk in at least 3 times per week for 30 to 60 minutes for these patients with symptomatic peripheral arterial disease. Again, I'd like to point to this slide again, the intermittent claudication, the outcomes. The most important thing that the practitioner need to look into is to decrease the risk factors, because the cardiovascular morbidity and mortality is very high, suggests if there is coronary artery disease. Now, what are the revascularization options? There are endovascular and there are open options. Usually endovascular options are designed for patients with a focal disease, or they're very high risk for open vascular procedure. The picture on the right side of the screen is indicating using balloons and stents in order to keep the artery open. The open procedures are using bypass and other techniques in order to revascularize the limb that is in danger. These are some of other modalities available, such as atherectomy devices, literally carving out the plaque from the inside the blood vessel, or laser, and then treating it with the balloons and stents as necessary. Post-operative management for these patients, again, it's important. Optimal medical management with antiplatelet, cholesterol, their blood sugar, and also smoking cessation. And the surveillance with the non-invasive, the ABI duplex, are very crucial. This is the reference I used from Journal of Vascular Surgery in 2016, which it's a very good reference for people that are more interested in peripheral artery disease and how to manage them. Thank you.